Good morning, everyone, and welcome to Bridges at Lakeview Health, our educational series developed to help our professional partners across the nation connect addiction and recovery education. We want to thank you all for joining us today. Dr. Lanty Elizabeth Jurenby will be presenting on the history and epidemiology of opioids in treating pain. Lakeview Health is an adult-only residential addiction treatment facility located in Jacksonville, Florida. We are celebrating 20 years this year of leading the way on how addiction is perceived, treated, and how recovery is managed. We are a passionate team of difference makers whose mission is to empower profound recovery through exceptional, dynamic, evidence-based care for individuals and their families. Our commitment to our patients does not end at discharge, but is continued through our aftercare and alumni support. Before we get started, I wanted to share a few housekeeping items. You can submit questions through the presentation via the Q&A section to the right of your screen. And at the end of the presentation, the presenter will answer any questions you have entered. The chat box is for conversation among participants. You are muted throughout this presentation and communicate via the chat. Please do not ask questions for the presenter via the chat box. Within 48 hours following the event, we will email participants the evaluation, post-test, PowerPoint, and the event. As a reminder, to receive the certificate for continuing education credit, you must be in attendance for the entire presentation, complete the event evaluation, and pass the post-test with at least a 70% score. Now, our presenter today is Lanty Elizabeth Jurenby, MD and Chief Medical Officer at Lakeview Health. Lakeview Health is a Jacksonville, Florida dual diagnosis, gender separate, and gender responsive addiction treatment center. Dr. Jurenby graduated with honors from Vanderbilt University with a Bachelor of Science. She attended medical school and completed her residency at the University of Florida. For 7 years, Dr. Jurenby worked as a staff psychiatrist and mental health advisor at the Veterans Affairs Outpatient Clinic. After completing her addiction psychiatry fellowship at Yale, Dr. Jurenby became medical director for the dual diagnosis unit at McLean Hospital in Belmont, Massachusetts, which is ranked the top psychiatric hospital in the States. She also served as faculty at the Harvard Medical School in the Department of Psychiatry. She is triple board certified in addiction psychiatry and general psychiatry. She is also a featured author in the September issue of Psychology Today on women in addiction, available at newsstands now. Thank you. And now over to Lanty.
Good morning, everybody. Danny and Allie, you can hear me okay, right?
Yes.
Great. I just only have my slide deck up, so I want to make sure I'm not doing this incorrectly. So welcome, everybody. So glad that we have a good audience this morning. As you can see, we are going to talk about chronic pain and addiction, and I'm actually going to weave us through some history as well. This month is Opioid Overdose Awareness Month, so I think this is a really appropriate topic to go over. Here at Lakeview Health, we do treat dual diagnosis disorders. We treat mental health issues, we treat substance use, but we also have a large population that comes in that are seeking help for chronic pain. They've often have become addicted to their opioids and other substances and are looking not only to restore and enter into recovery, but to really get a handle on what's going on physically. And so here at Lakeview, we do a thorough assessment. So I'm going to walk us through some of the things that really are key when one is evaluating and treating someone with chronic pain. I'll go ahead and jump forward and just kind of talk a little bit about what we're going to look at today, our objectives. So we'll review the epidemiology of pain and addiction. We'll go over the history of pain theory and the different types of pain to consider when you are evaluating somebody. We'll talk about the neuroscience of pain and the neuroscience of addiction. We'll discuss how to assess chronic pain and addiction and treatment methods for pain that really dovetail with someone that's in recovery. So just a few numbers I'm going to throw up first. These are numbers that I've pulled from the National Institute of Drug Use and Health, National Institute on Drug Abuse. We'll pull this from the National Institute of Health as well, and also from various pain societies. So we do know that chronic pain affects 100 million Americans, and chronic pain is actually the #1 reason that people file for disability. Prescription opioid use for chronic pain actually increased exponentially in the medical community in the 1990s through the 2000s, and we'll go over a little bit of history around that. Approximately 5 to 8 million Americans currently use opioids for chronic pain treatment. Opioid prescribing increased threefold over the last 20 years, and I believe that number actually has gone up since that was studied. In 1991, there were 76 million opioid prescriptions that were written in the United States. And then in 2011, we were up to almost 220 million prescriptions. 80% of prescriptions written worldwide for opioids are actually written here in the United States. And this schematic is just to highlight how far out the US is for prescription opioids. You see, starting at the very top, you have Greece, Italy, Finland, and you can see those numbers just increase as we get closer to the very bottom, which is where we are, the United States. Canada, a little farther behind us, but not by much. And I just think this is meant to emphasize and really highlight that the US specifically has really embraced opioids and opioid prescriptions. As I mentioned earlier, prescription opioids have been aggressively prescribed starting in the mid-1990s through the 2000s. A lot of this prescribing started without really clear evidence that opioids were safe or effective as long-term treatment for pain. We know that the increased availability of prescription opioids has actually fueled this opioid epidemic, and prescription opioid use is a risk factor for heroin use. And if you can see the schematic down here, if you look at around the mid-1990s, the colored in boxes, that represents heroin. We saw a dip in heroin use around the 1990s and an increase or uptick in the prescription opioid use. And this kind of tracked for about 10 years. And then in 2010, we saw that opioid use was going down and heroin use was going up. And what happened in 2010 very specifically, Purdue Pharma actually came out with a tamper-proof OxyContin, which really reduced the ability for people to misuse, abuse, and divert OxyContin as a prescription. Additionally, around mid-2000, 2010, many states enacted what we call the prescription monitoring databases. 48 states actually right now have one of these databases in place where physicians are required to check the database before they prescribe an opioid or a narcotic. And that was really to curb doctor shopping. That was really rampant, probably in the mid to late 1990s and 2000s. So once we saw that reduction in access to prescription opioids, people found that heroin was easier to access and actually cheaper. And that's why we see that uptick. When we think about pain as it is in modern medicine here in the United States, pain was considered the 5th vital sign. This was in 1996. And in medical education, addressing pain as a vital sign was really baked into the curriculum, both at medical schools and in residency programs around the country. In 1996, that was the same year that OxyContin was FDA approved. And OxyContin is basically a long-acting version of morphine, or I'm sorry, of MS-Contin, but it's a long-acting version of oxycodone. And oxycodone is actually a much stronger opioid than morphine, even though the perception at the time was that it was safer and less potent or less addictive. There is a risk that often doctors are now just understanding, probably in the last couple of decades, of opioid-induced hyperalgesia. That is a term that we use that describes someone who has been in chronic pain for quite a while and are treated with opioids. This actually can increase their risk of pain. Their pain becomes greater when they're on long-term opioids. And opioids have been proven to increase risks of morbidity and mortality. We know that there's risk with overdose. We know that there's risk with respiratory depression. But what we're discovering as well is there's actually risks to cognition, heart, respiratory diseases, infectious diseases. And there's, again, very limited evidence out there right now that it improves pain and quality of life with opioid treatment past a certain period. And that period appears to be around 12 months. So I'm going to just take us back in time a little bit and look at the history of pain theory. So this is BC, and we're talking about Hippocrates, the father of medicine, Greek father of medicine. So he described pain when pain was discussed in his era. Pain was due to what they call an imbalance of fluids. The body was considered to have a number of different fluids. Those fluids need to be in balance: blood, water, and pain was considered that imbalance. Aristotle took this and ran with it and said pain actually is different. It's not necessarily an imbalance of fluids. He called it the opposite of pleasure, and he labeled it as an emotion. And I think that's really important to remember because we're going to come back to that idea. René Descartes, philosopher in the 1600s, French philosopher, actually studied a number of different topics, but he was also interested in medicine. He was interested in science and physics. But he described pain, he talked about pain in his writings, as a nerve signal that operates within a fixed and measurable system. And René Descartes, also a very Renaissance type person, loved to look at hard data, science, mathematics. So when he gave this description to pain as a fixed and measurable system, that is what we've derived our current modern medical theory on pain. So we call that the Cartesian model after René Descartes. It's a 350-year-old model for pain. And it really goes back to the idea that pain is something that we can measure and specifically identify. So early AD, pain takes on a different type of theory or meaning. It's central, if we look at religious history, it's central to Judeo-Christian thought. It has a meaning. It has it's more than just pain. It's more than just a physical presence. We look at early Christian theory and early Christian philosophy. We look at Job from the Old Testament. We know that Job was one of God's chosen, but he endured several trials, physical pain, emotional pain. And pain really was a meaningful part of Job's life. If we look at the New Testament and the story of Christ and the crucifixion, pain also takes on significant meaning in this period of time. Pain was required for Christ to take on the sins of the world. We also have learned through study of pain early on in the early part of the AD millennium is that it's considered a pleasure, balance of pleasure and pain. It really is meant to determine the good of society. So when we look at these early writings about pain, pain really was a good thing in many ways. People saw pain as something that was required to give meaning to life. Later in the 1600s, morphine and opium was discovered. The opium plant became very important in British trade and industry. And laudanum actually emerged in the 1600s. It was part of the physician's toolbox. Laudanum is basically opium mixed in sherry and was used regularly to help with emotional pain, physical pain, sleep, trauma. And pain was, again, still measured as a patient's vitality. One physician is quoted as saying, "The greater the pain, the greater must our confidence be in energy and life." So again, pain is really depicted in the early part of the millennium as something that's very necessary, it gives vitality to somebody's life. It has a lot of meaning. This evolved into a different theory, and in the mid-1800s, romantic poets and utilitarian philosophers began to talk about pain in a different way. They started to advocate for the individual experience. And when they talk about pain, whether it be physical or emotional pain, it was really to help people figure out how to reduce their level of pain. So it was really about what that person subjectively experienced. Also in the mid-1800s, we discovered anesthesia. So surgical anesthesia was not present prior to this period of time. Patients were operated on with rudimentary pain measurements or pain control. And once ether was introduced into the medical field, physicians were actually quite polarized by whether this was a good thing or not. They really still had this understanding of pain as something that was good. And if you removed pain from that patient's experience, you could actually slow the healing process. This was something that was really a very polarizing thought, was using something like anesthesia. Opioids were also standardly used in the 1800s, but mostly for pain complaints such as headaches, generalized pain, abdominal pain, things like that. Bayer actually developed diacetylide morphine in 1898, which was actually heroin, and they marketed it for cough. However, what was discovered was that and it was pills, heroin pills, and what they eventually discovered here in the United States and abroad was that people could divert those pills, crush them up, snort them, use them in other various ways to become intoxicated. And this kind of street value that heroin developed in the late 1800s and early 1900s led to what we know here in the United States now as the Harrison Act, which prohibited the use of certain narcotics, heroin being one. Another thing that we found in the 1800s was that we were using opiates to treat patients that had a lot of cancer. Cancer pain, end-of-life pain was something that was very noble to treat with opiates. And in fact, a physician actually was quoted as saying, "Seldom does it provide more pride to be a physician. One of the chief blessings of opium is to grant a painless death." And so again, this is kind of an evolved new theory of pain, looking at pain for end of life, looking at alleviating suffering. And suffering at end of life is not just physical suffering. We all know that there's emotional suffering, grief, and loss that's going on with that. Another thing that happened in the late 1800s was the U.S. went to civil war. And a result of the Civil War in the 1800s in the U.S. was that we discovered something called phantom limb pain. And it isn't necessarily something that we discovered. The Greeks were aware of it, many other civilizations. But here in the United States, we had a vast number of soldiers returning back from war, veterans who were struggling with loss of limbs that had been on the battlefield. And they continued to have pain, even though they had lost their limbs. And so this was something new that medicine was starting to learn about. It was something that was called pain without lesion. You couldn't necessarily see the pain per se because the limb had been removed, or there was pain from post-traumatic stress disorder. And this whole concept of pain was very unique now. Medical schools started to look at pain in a different way. Additionally, they embraced something called specificity theory of pain. And the description of specificity theory of pain in a very succinct way is that pain is directly and proportionally related to a noxious stimulus, an injury. If you look at that specific definition and compare it with what we saw from René Descartes, the French philosopher in the 1600s, that is a very similar definition. There has to be an injury that is directly related and directly proportional to that injury. There's going to be pain. Also in the 1800s, Freud and his salon of followers actually were starting to pursue pain as related to the psyche and mental disorders. And so pain actually had a couple of different meanings in this period of time. In World War II, mid-1900s, or mid-1900s, we saw a change again, or a shift again, about what pain was. A Harvard physician, Dr. Henry Beecher, discovered that he did some scientific studies and saw that patients with in the recovery rooms of the Massachusetts General Hospital, where he worked, were actually reporting higher levels of pain than on the battlefields of Europe. Soldiers that were on the battlefields undergoing significant limbs and injury, significant limb injury or physical injury, are actually showing less pain than those that were undergoing surgery in a controlled setting. This kind of led to a theory of pain related to cognition and emotional components. So being aware of pain is important here. There is a doctor in Britain, Dr. Cicely Saunders, who actually developed a hospice model for dying patients. This model was to address social and spiritual and emotional concerns around pain and end of life. So you can see pain and pain theory really doesn't fit one specific box or one specific category. In the late 1900s, pain evolved again in our understanding of it. As you can see, I have a schematic of the brain and spinal cord, so the central nervous system. 1965, Melzack and Wall developed what we call the gate model, or the gate theory of pain. Very simply, this is a theory that says that spinal cord mechanisms are regulating pain transmission between the periphery and the brain. So the periphery meaning the arms, the legs, the physical body, and what's transmitted to the brain. Again, we're getting at a very specific, measurable type of definition for pain here. In 1973, Dr. John Bonica formed what we now know as the International Association for the Study of Pain. And he did this because over his life and his career, he really wanted to understand pain better. There really aren't specific or helpful definitions that he was seeing. So he formed the society to really look at a way to look at and understand pain in a more interdisciplinary approach, meaning using many different fields and many different modalities. So this all takes us to where we are now, which is the 21st century, pain theory. The International Association for the Study of Pain, you can see here, they actually came out with a new definition 4 years ago in 2017. And their definition basically is that it's an unpleasant sensory or emotional experience associated with actual or potential tissue damage. And I think that's really important to see, because we start out in the very beginning with an understanding that pain is an emotion. Think about Aristotle's description. We rotate through Descartes, his need to measure pain, very specific thing, as a very physical thing. And now we're actually kind of swinging back to the other end, where we're looking at pain not just as a sensory or physical experience, but also as an emotional one. So this new theory is really integrating a number of others. They also describe pain as you don't need the ability, or you can have the inability to communicate pain verbally. That doesn't mean that it doesn't exist. And I think that's also an important piece of it, because often when, as a physician myself, I have patients coming in to see me and they're telling me they have pain, but they're not necessarily able to verbalize it. Their ability to describe it or characterize it may be impaired. And so understanding that they are still in pain and that pain needs to be addressed is part of that new pain theory. Dr. Clifford Wolf of Harvard Medical School also describes pain as existing in 3 different types. And we're going to hit on some of these in the next few moments. Nociceptive pain, inflammatory pain, and pain relating to a pathologic state. And again, I think that we're seeing an evolving pain theory from the pre-millennium to where we are now. A lot of these concepts are really integrating more and more the more we understand pain. So we'll get into that in a little bit. I think it's also important to understand that pain can be a teacher, can be something that teaches us as humans. So we know that pain actually is a human defense mechanism. Thinking back to the early part of the 1800s where doctors considered pain as a good thing, pain is a good thing in many ways because it teaches us to take ourselves out of something that's dangerous, toxic, or lethal. If you think about that hand on the hot stove, for instance, we all learn that as children. We touch something that's unsafe, touch something that can hurt us, our pain receptors tell us to take ourselves out of that situation. As you can see here, for instance, unsafe things hurt. Pain goes down when your brain thinks it is safe. And then be patient and tough, Ovid said. Someday this pain will be useful to you. Some more nuanced definitions of pain that actually have come out in the last few decades include something by Bessel van der Kolk. I pulled this from one of his very seminal books on trauma. Mindfulness has been shown to have a positive effect on numerous psychosomatic, psychiatric, and stress-related symptoms, including depression and chronic pain. And many of you may be familiar with Bessel van der Kolk. He writes on trauma, emotional trauma, and how it can be very integrated into physical symptoms and physical pain. An unresolved emotional trauma held within the body, pain can be considered that as well. Levine and Phillips discussed that in 2012. What we do know as well is that pain is just not well treated. And again, these statistics I've pulled from various government agencies that have been measuring pain and measuring effectiveness for treatment. So 69% of people who have tried opioids for pain, 58% have found them effective. So a little more than half. 32% of who have tried surgery for pain, 54% have found that surgery fairly effective. And then 48% of people have tried physical therapy, PT. Only half of those, or a little less than half, actually found it effective. So you can see here, it's really a 50-50 kind of measurement in how effective people find pain treatments that are out there. And these are some of the most standard treatments that we have available right now in modern medicine. I have here a list of different types of pain. So I'm going to go through these different types of pain. By no means is this an exhaustive list. Please know that there are various other pains that are out there, and certainly this list certainly can expand at some point too. I think we're seeing newer types of pain. I think our theories are evolving. But we'll talk a bit about acute pain. We'll go into what chronic pain is, and I think it's going to be important to have those definitions, because those are really, those definitions kind of break down for us what you're normally going to see in the office, or in the physician office, or in the therapy office. We'll talk a little bit about breakthrough pain, bone pain, soft tissue pain, neuropathic and referred pain, and then phantom pain. So just a little bit about what acute versus chronic pain is. Acute pain is transitory. It remains until that stimulus or that offending substance is removed. So you can see here we have a bee sting on a hand. And so once that bee flies off and your hand is starting to swell and it looks hot and warm, that's an acute pain. It may not hurt as much as it did when that bee was there. So the removal of the stimulus is transient. So chronic pain actually, though, begins about 3 to 6 months after the start of the pain. So chronic pain is where you have the injury and it doesn't heal. And this is where it becomes a little less clear, a little more of a gray area. And this is where people start to present to their doctor's office, because they've initially had the injury, they've gotten treatment. Let's say they broke a bone, they got that bone healed, whether it be through a cast or surgery, and then they come to you 3 to 6 months later and they continue to complain of pain. This transition from acute to chronic pain actually can go up to 12 months. Once you get to that 12-month mark, what we know about the body, what we know about healing within the body, whether it be nerve damage, bone, tissue, all of that, once it's past that 12-month mark, really is where that expected time of healing should have occurred. Once you have pain beyond that, that's really where chronic pain takes over. Now, if we think about chronic pain, we also have to think about breakthrough pain. So this is an example of what we normally see perhaps with someone who has cancer. So this is very common in cancer patients. They have that background pain, that kind of chronic pain, whether it be from bone cancer or other types of cancer, abdominal cancer that hasn't healed or hasn't been treated. And all of a sudden they come into you and they say, I have shooting pain in my neck, or I have shooting pain in my back. That is where that breakthrough pain comes in. You have the background pain that's just kind of low level, and then that kind of sudden, sharp, or transitory pain that isn't relieved easily. Soft tissue pain. Soft tissue pain is injury that's related to the muscle, ligaments, tendons, bones, nerves. This is type of pain that we'll often see when there's been acute injury. Inflammation really can cause soft tissue pain or contributes to it. There's something called cytokines. These are small proteins that when you have an injury to soft tissue, those cytokines are messengers. They send messages to different parts of the body and different systems in the body, telling the body there's an injury and please come help. So when we have that kind of release, we see inflammation, we know there's swelling, redness, pain. This is all part of soft tissue pain. And highlighting Lady Gaga here. So I know this seems a little bit out of the context of what we're talking about, but it's actually pretty relevant. So Lady Gaga actually was diagnosed with fibromyalgia. I'm not entirely sure when, but probably about 10 years ago, and talks pretty openly about it now. She discusses her pain levels. Fibromyalgia is an injury or a pain of the soft tissues. And so I think it's important to highlight that. Again, fibromyalgia is a very common pain presentation that psychiatrists actually see, that primary care doctors actually see. It's a hard to describe type pain. A lot of times patients come in and they feel pain in their joints, their muscles ache, they have a lot of fatigue. And so again, that concept of soft tissue pain, inflammation is important when we think about fibromyalgia or other types of soft tissue. Neuropathic pain, you may have heard of this term as well. Sounds just what it is. Neuropathic pain is pain injury to the nerves. It can be the central nervous system, the spinal cord. As you can see in this schematic here, you can see parts of the spinal cord that's being injured. It can also be the peripheral part of the nervous system. So that means nerves in the arm, nerves in the legs, nerves in the back that have led from the central nervous system or that spinal cord. It can be caused by compression, injury, crushing injuries, things like this, severed nerves, people that have had traumatic injuries to their neck or their back, who might have lost use of their limbs. These are all things that are considered neuropathic pain. Interestingly enough, also certain types of diseases cause neuropathic pain, autoimmune disorders, vascular disorders, metabolic diseases. And the type of pain that neuropathic pain causes often is characterized by burning, tingling, pins and needles. These are kind of the buzzwords that you'll hear when people are trying to tell you what type of pain they have. Phantom pain is a type of neuropathic pain. So thinking back to our earlier slide where we were talking about the Civil War in the United States, a number of soldiers coming back from the war had lost their limbs on the battlefield. Yet they continued to tell their doctors that they had pain where their right arm might have been, or they had pain below their knee when there is no below the knee left. And so this is a phenomenon that is still difficult to wrap one's brain around. However, it is described as pain that's felt in the body when the brain is no longer receiving neural signals. So if you think about it, if you no longer have that hand, but your brain is telling you that hand is there and that pain is still present. Interestingly enough, 82% of people who have lost upper limbs still experiencing phantom pain, and that is 54% of lower limb amputations. Alodinia is just an interesting type of pain. It's pain that's elicited with light touch, whether it be from clothing, pressure. It's often described as burning and excruciating. This is also a type of neuropathic type pain, but it's a little bit different. It's not necessarily the nerves so much as the glial cells. Glial cells are support cells in the nervous system. They help with healing. They help with nutrition to those nerves. And so with glial cells, if they've become injured or affected in any way in a state, Alodinia is a common symptom. I always like to talk about referred pain too. And this is a lesson that was hard learned when I was in medical school. And when we think about referred pain, it is basically pain felt at a location where you don't have an injury. So it almost sounds a little bit like phantom pain, but not quite. And as you can see here, we have a map of the body. I have some of the internal organs are highlighted there on the right and the left. And those organs are also innervated by nerves in the central nervous system. If you have an injury to the gallbladder, interestingly enough, the nerves that sustain or help that gallbladder also go up to the shoulder. So that right shoulder is affected when the gallbladder is affected. And people can come in, I learned this again in medical school, people coming in telling you they have terrible right shoulder pain. You decide, well, I'm going to image that shoulder. I'm going to see if they need physical therapy. And turns out they're actually having gallbladder disease. Once you take the gallbladder out, boom, their shoulder pain is gone. So I think this is an important category to talk about is psychogenic pain. And we're going to go into this a little bit more towards the end of my presentation. But when you look at the evolution of pain theory, we started out with Aristotle telling us it's an emotion. We revolve through again to the different theories where it's something fixed and measurable. Coming back again to the idea that it's an emotion, it is psychogenic pain specifically is pain that's caused by mental or psychological suffering. I think it's important to understand that patients that have psychogenic pain, and I think psychogenic may be an old term and it has lost favor, but it's still used. It can also create or be associated with stomach pain, headaches, and back pain. And there's been a number of studies that have looked at a lot of correlation between people that present with headaches or gastrointestinal abdominal pain, irritable bowel syndrome, or other types of gastrointestinal problems. There's often a component that's related to mental or psychological suffering. There's more to be discovered in this area, but there's definitely strong associations that we're seeing here. So that's why I highlight here Oprah Winfrey. Oprah Winfrey is somebody that we all know, obviously. She has been pretty open about her early childhood. She has a book that she's written. She's given interviews. She's talked a lot about what she suffered as a child as far as sexual abuse and trauma, very young, pregnant as a teenager, very tumultuous and kind of chaotic family life. And she talks openly about her emotional pain issues and how there appears to be a correlation for her with her physical health. And I think that's, again, important to highlight when we're working with patients, myself as a psychiatrist, when I'm working with someone who comes in with the emotional burdens, the emotional suffering, and they also have that associative physical issues. I think there's really a strong component that a lot of us are still not recognizing. And I say us, meaning my field, medical field. C.S. Lewis, well-known author and philosopher from the 1900s, World War II era, he described pain as mental pain is less dramatic than physical pain, but is more common and also more hard to bear. The frequent attempt to conceal mental pain actually increases the burden. It is easier to say my tooth is aching than to say my heart is broken. So circling back to what we think about as far as pain, we've talked a bit about the types of pain that we can recognize, although not exhaustive, that list. We've talked about what acute pain looks like, talking about psychogenic pain. I think it's, again, important to think about chronic pain. What exactly is chronic pain? So if you remember that time definition I gave you earlier, 3 to 6 months is where chronic pain starts to take over. If it persists past 12, then we're definitely in that chronic pain phase, because that's when you start to see healing complete. So chronic pain For the number one definition, if we think about chronic pain, is really almost always a mistake of the brain's alarm system. It's when our brain is kind of tricking or fooling us. So if we think about what acute pain is, we have that physical injury, let's say a limb that's been injured, a broken bone or a burn. That pain, that acute pain, changes the nervous system and the immune system because it's seeking healing. You've got the cytokine release, you've got the inflammation, the body's on alert, the body's trying to take care of that injury. Acute pain can amplify and cause an increased sensitization of those areas, again, because it's seeking healing. But that sensitization in chronic pain never really turns off. After the healing is complete, that alarm system in the brain and those tissues still is going off. It's a red alarm fire when the fire's been extinguished. The immune system specifically has been studied as sensitized or oversensitized in chronic inflammatory states. So you have all of these systems that are working together to heal that acute injury. And somewhere in that mix, that alarm system never goes off. So why do we think that is? Again, that's Rene Descartes, not a terribly flattering picture of him, but if we think about pain, he described pain as a very specific injury. It has to be measurable. You have to be able to directly relate it to tissue injury. He was a very scientific guy, very mathematical guy. But what we are learning is that approach to measuring and looking at pain actually has triggered what we call an overuse of imaging. Everybody gets an MRI now. Everybody gets a CT scan. We are always sending somebody instead of listening to the patient and examining the patient. A lot of times doctors knee-jerk is to send them to that MRI. And so pain management approach for chronic pain has commonly, up until more recently, been mainly focused on medications, surgeries, very physical interventions, things that you can measure and actually see. New theories, though, which I really take comfort in, are actually looking at what is wrong with that theory. Tissue injury doesn't always correlate with pain levels. Mosley talked about that in 2012. So I love this example. This is, I don't know how many of you recognize this gentleman, but this is Mateo Mitchell. He ran in the Olympics in London, I believe, in 2012, represented the US, there he is. And he has a very interesting story. So in 2012, he's preparing for the 4x400 relay. He's got the baton there in his right hand for the trial. So you have to do a trial to make it to the actual relay. And so you have a number of countries just trying to get in the top 3 trials. And he was the first one out. Oh, no, I'm sorry. He wasn't the first one out of the box. I think he was taking the baton from somebody else. So he's quoted as saying, and I'm going to show you a picture in a moment that explains all of this, but he's quoted as saying, "As soon as I took the first step, I felt it break. I felt like someone snapped my leg in half. I knew if I finished strong, we would still get the baton around. I saw Josh motioning to hand it off, which lifted me. I didn't want to let those guys or my team down. I just ran." They finished second in the trials and qualified to do the 4x400. Let me show you what he's talking about. This is not his fibula. This is a broken fibula, and this is exactly what happened to him. He had injured his foot or his leg the night before, walking down a set of stairs and slipped. And then when he goes into the trials that next day, his fibula snapped. It's not clear exactly what was going on, but this is painful. You can see that red highlighted area. That's a broken or fractured fibula. However, this gentleman was able to get through that 4x400. He ran for 45 seconds on that broken leg, and his team finished second in the trials and was able to advance to the final relay. And I think this really highlights, if you look back, let me just take you back to Rene Descartes and his idea that you can measure that injury. You can say that injury has directly created this level of pain. That really doesn't apply. You can't make sense of it. So there's got to be something else going on here. I want to just take us through a little bit of neuroscience of pain. I'm not going to spend too much time on this. This is a kind of over busy slide, but I think it's just important to understand that's a neuron or a neural cell. It's cell in the brain, and it's how it communicates with each other. You can see the big yellow one is the neuron, but you've got all these support cells, the yellow ones, the red ones, astrocytes, glial cells, oligodendrocytes. All of these are just support cells, but that neuron communicates with a million other neurons through chemicals. And this is why sometimes if you think about pain, why is it so complex? Because the brain is very complex. You've got membrane receptors. They sensitize to hormones, to inflammation, neurotransmitters, neurochemicals. There's a lot of signaling that happens not between 1 and 2 cells, but many cells. And what I think is interesting, if you think about that schematic and you apply it to what we know about pain, pain is actually something that is becoming more and more understood as not just a neural signal issue. So you have an injury, your brain and your spinal cord are transmitting this injury. However, there's more to it than that. So in March of 2019, just a couple of years ago, National Institute for Drug Abuse, actually researchers, they identified what they call the kappa opioid receptor system. And it's an opioid network deep in the brain. They found it in what we call the nucleus accumbens, which is really central in that area there, kind of in the blue area. And that nucleus accumbens is part of what we call the reward system in the brain. So when the body senses pain, it sends signals to the brain through that spinal cord, and the nucleus accumbens is actually triggered as well. So the nucleus accumbens, part of the reward center, is receiving signals. And those signals actually can trigger what we call a negative emotional state. So we're talking about emotions again. What these researchers interestingly discovered is when you block those neurons that are part of that kappa opioid receptor, you can actually see a decrease in the negative emotional component of pain. So again, we cannot simply apply that Cartesian model. There is more to pain than we ever really understood, and we're learning more about it every day. I want to throw up a little bit about addiction because that's really a big part of what I'm talking about today. I've taken you through a lot of pain theory, but I think it's also important to understand that addiction and pain are actually quite connected. So we know what drug use is. It's the use of illegal drugs or the misuse of prescription or over-the-counter drugs, which result in negative consequences. Someone drinks too much and they get a DUI. However, addiction is a little bit different. It's the amplification of those negative consequences. It's in continuous compulsive use with loss of control, so those 3 C's, despite negative health and social consequences. This is where someone simply cannot stop. Their behaviors have become so compulsive that their life has become out of control. Another brain schematic here, and I like to just highlight that because that area of the brain that is taken over by addiction is also some of the same areas where we're seeing pain receptors activated. And when we think about pain, we think about addiction. If you're using those same pathways or similar pathways in same parts of the brain, it's almost impossible not to cross pathways. So you're definitely going to see where people can easily develop an addiction when they have pain. There's a lot of neuroscience that's kind of crossing pathways there. These are pathways that are reward center pathways deep in the brain. You can see that VTA area. These are pathways that should be triggered by good experiences, social bonds, food, sex. These are all good things that trigger reward. But when drugs or alcohol are used compulsively, those parts of the brain are taken over by substances. And again, just highlighting kind of some of the same structures that are involved with pain are also involved with addiction. It's important to understand that addiction takes the brain hostage. It's tricked into thinking it needs that substance to survive. So let's jump into what one might do when you're presented with a patient that's coming to you. They have an addiction. This is where I commonly see people coming into Lakeview where we're treating them for, let's say, an opioid or even an alcohol addiction, the top 2 substances we see people seek treatment for. How do we assess them? Because we know, and I commonly know, that people are coming in not necessarily because they wanted to be opioid addicts or they wanted to be addicted to fentanyl, but they legitimately had pain in their earlier life. an injury, physical injury, or some form of accident. And they developed a tolerance and then eventually an addiction to their pain medication. So when we assess for someone that has pain and they're being treated for substance use, we have to look at risk factors. So risk factors for addiction in the face of chronic pain, they're numerous. Some of the key things, though, that we look for are a history of non-opioid or opioid substance use. So that history of addiction is important. A family history of substance use, which is very key, because when there's an addiction, or I'm sorry, when there's a genetic component, it's very common to see that a father, a grandfather, or a child has developed that same or similar addiction. A personal or family history of mental illness. And again, this is linking that idea or concept of mental or emotional trauma or suffering to the understanding that there's a pain component as well. We look for trauma history. Trauma is also key when we look at addiction. And trauma, thinking about, for instance, Bessel van der Kolk's work, trauma, it can be very inexplicably tied to physical symptoms. We also look for a history of noncompliance to treatment and medication therapy. These are all risk factors. How do we assess? So again, of course, we're going to try and do a thorough medical history. We're going to try and get as much information from this person as we can, talk to their family, get collateral data. But we're also going to do a very thorough medical exam. And so one of the benefits of where I work is that we have access to a number of laboratory studies. We can do a number of psychometric testing and screening. So we're looking for what we call psychiatric comorbidities, depression, anxiety, mood disorders, trauma. Trauma, again, being a key thing here. We use brief pain inventory scales. So the BPI we use commonly with all of our pain patients. Actually, we do this for everybody that comes in. There's also other options out there. So there's the McGill Pain Questionnaire, the Chronic Pain Acceptance Questionnaire, DSM-5 criteria. Again, we're looking for co-occurring disorders. We're looking to see if someone has an actual substance use disorder, but we're also going to look for co-occurring disorders like alcohol, benzodiazepines. It's very common to see that there's more than one. It's actually uncommon to see it's just opioids. So if we kind of walk through what treatment is, we have to think about pain education, body scan, neuroplasticity. We'll talk a little on anti-inflammatory diet, movement, psychotherapy, non-narcotics, digital therapeutics. So just a little bit about education. And when we look back at the International Society for the Study of Pain, one of their big key components that they're proposing now is that we really need to educate our patients. The Institute of Medicine actually came out with a pain treatise back in 2011 that also emphasized education. So what we know about pain education is that in and of itself, aside from anything else, whether it be physical therapy, pain medication, surgery, pain education can actually be beneficial. So a study by Michael Off in 2014 actually looked at treatment outcomes for a small group of patients suffering from whiplash injury from an automobile accident. So they separated their groups. One was exposed just to pain education, kind of what I walked us through earlier. What is pain? What types of pain are out there? How does the nervous system respond? The second group was exposed to 20 sessions of physical therapy. And at the end, their outcomes actually showed that the people with pain education reported better pain control than the ones in the physical therapy group. Now, this is a small study. I think it's been replicated a couple of times since then. It's just an interesting kind of concept to think about. Again, education being key. Neuroplasticity. Neuroplasticity is a term that you may be familiar with. It's really the ability of the brain to change and adapt and shift resources throughout one's life. The younger you are, the more plasticity your brain has. That's why often children that have brain injuries can heal better than someone who's older in life in their 30s or 40s or 50s. It's really looking at neuroplasticity, looks at the brain being a muscle. So if you exercise it, you challenge it, it's going to respond. It's going to be able to, again, like I said, shift resources. assign or allocate a function to another part of the brain from the part that has been injured. This involves rewiring pathways, especially people that might be stuck in addiction or pain patterns, learning new habits, challenging new patterns, new activities. This can include movement, cognitive exercises, learning new skills. There's a small Israeli study in 2016 that showed that the brain can be trained to regulate negative emotion, reducing activity in the amygdala. We didn't talk too much about the amygdala, but that's one of the emotional parts of the brain, one of the emotional centers. A little bit about diet, and this can be a whole nother webinar, but diet actually has gotten more attention, I think rightly so, because there is a fair connection between diet and physical health. And so what we're learning more and more is that inflammation can definitely be affected with what we eat. As you remember, inflammation can be part of a response to a soft tissue injury or even to a metabolic disease or disorder. So if we're eating foods that make our inflammation worse, and often alcohol is a big one, a big offender, so is caffeine, so is sugar. We are lucky here at Lakeview. We have a nutritionist that helps us and guides our patients. We target diets that are higher in fiber, low in inflammation, or low in inflammatories. And this can help, they've studied to help reduce pain in fibromyalgia, IBS, and migraines. Another kind of celebrity here I wanted to highlight, Heather Mills. She actually is one of these supermodels that lost her leg in a motorcycle accident, and she attributes changing her diet, she's a vegan now, and changing her diet to help with healing and pain management. Some of you may be familiar with Jon Kabat-Zinn's work out of University of Massachusetts. He developed what we call mindfulness-based stress reduction. One of his earlier works and published in JAMA in 2016 showed that mindfulness-based stress reduction along with CBT actually reduced chronic back pain and improved function limitations over what we call care as usual. And care as usual is, in often a lot of these studies, surgeries and pain medications. MBSR involves scanning the body partly. There's other components to it, but it's learning to understand what your body feels like. Being able to scan your body and measure the size, the weight, the temperature, the space, how connected is your limbs to your rest of your body. It's very meditative based. A study in 2015 by NIDA on mindfulness showed that treating chronic pain patients at risk for opioid misuse with either a support group or mindfulness showed that people with mindfulness actually were able to pay more attention to positive aspects of their life and actually kind of change what their brain saw as a natural reward. And again, thinking back to the schematics of the brain, that whole reward system has been taken over sometimes by substances or addiction. And if you can shift what we see or perceive as a natural reward, that can be very helpful. And just an example of what we do with body scans, you initially start out by using words that are very simple, words that are rooted in the five senses. Again, how hot is your limb? How much does it feel like it weighs? What do you smell? How do you hear your environment? All of those things are part of that mindfulness body scan. I highlight a little bit here. This is a little bit on SEAL team meditation, still kind of sticking with the whole idea of mindfulness. These are SEAL team members are very elite military group that have to compete to get into their program, to get into the SEAL team. They have to run 1.5 miles in 11:30, 500-yard swim in 12:30, 42 push-ups in 2 minutes, and 16-second breathing exercises. So this is kind of their regimen for training. And they participate in what's called the Navy SEAL box breathing technique. So it's an inhale for 4 seconds, hold for 4 seconds, and release. Very similar to other type of meditative breathings. I think this is just interesting because these are warriors. These are guys that are very, there's a lot of hubris involved in their training. There's a lot of, we have to control pain. We're not going to, allow pain to take over our minds. And I think that they use this type of meditation to really emphasize and control that. And you can see, I think it's interesting too, if you can see the t-shirt on one of these guys, it says pain is weakness leaving the body. And I find that very interesting if we kind of hearken back to what we talk about in the early or mid 1800s about pain being something that helps with healing. Seems like we're coming full circle here. Movement. I think it's very important when we're working with someone who has chronic pain, has had injuries, they're in a recovery mode, they've gone through a substance abuse treatment program, and they're going to need to figure out how to move again. Be physical, because often the patients that we see, they've been on pain meds for a long time because they're afraid of being in pain. That pain was so debilitating that they really limited or curtailed their movements, their mobility. One of the things that I like about what we do where I work is that we provide physical therapy to anybody who's interested in taking advantage of it. And a lot of the patients in our pain track do take advantage of it. It's the physical therapists that work with us understand how to help people find ways to move without being in fear. And really the target is to just move below that alarm system going off. And often you can start with just visualizing movement. You don't have to jump right into the physical aspects of it. And learning to move differently, just retraining your nervous system. So these are just various kind of examples of the type of movements that we encourage. Water, walking, yoga, gentle movements. I've talked a little bit about, well, maybe a little bit more than a little, about the emotional aspects of pain, and I think it would really be important just to highlight that psychotherapy really should be part of managing someone with chronic pain. The more we learn about the chronic pain the syndrome that is out there, the more we understand that those parts of the brain are very connected, I think the better off we're going to be when we apply psychotherapy to our patients. There's something called ACT, or acceptance and commitment therapy. It allows or helps patients accept pain in non-judgmental ways. EMDR, which I absolutely love. Early studies actually are showing that treating trauma, emotional trauma, can reduce pain. And again, getting back to Bessel van der Kolk's work. Cognitive behavioral therapy, again, can be very important. Patients with chronic pain tend to catastrophize and distort their understanding of perceptions of their world and of their physical health. And so really challenging patients on those distortions, helping them reevaluate how they describe their emotions, their pain levels, their capabilities, can be very effective. And then non-narcotic medications. I believe opioids will always be problematic, and we can spend another couple of webinars talking about opioids. And I think for my population, the ones that struggle with substance use, opioids will never really be where I go with them. And we have to look at other options for helping them manage their pain. And a lot of these can involve safer medications, although they all have their side effects. Inflammation, GI problems, kidney failures for NSAIDs, SNRIs and SSRIs. There's newer versions that are used for fibromyalgia, low back pain. I think it's interesting to note that, again, that these are also targeting emotional suffering. Tricyclics, an older generation of antidepressants, definitely have their high risk for side effects, but can be and have been very effective for treating pain. Different types, as you can see. Anticonvulsants, and I think just one to highlight here is gabapentin. I, in my practice, really are very cautious with gabapentin. It has been linked to a number of problems with abuse, especially with those who have opioid abuse or opioid use disorder. And in several states now across the country, it's considered a controlled substance. Wouldn't be complete if we just talked a little bit about cannabinoids. And these are definitely a growing area. CBD or cannabidiol does have, there is appearing to be some benefit, but there's easy accessibility and very poor quality control. And so I think that has to shift in the future. Many products still contain a small percentage of THC, and efficacy is still not there yet. We still don't know enough to say that this is fully safe and effective. Medical marijuana, a number of patients that I see are struggling with pain, and they have looked for medical marijuana relief. There's still risk for addiction and relapse. Impaired cognition has been shown with regular chronic use. And interestingly enough, medical marijuana laws have not been associated with a reduction in opioid use in certain parts of the country. I'm throwing this last slide in because I think it's important, and it's an emerging area, not just for chronic pain, but for mental health as well. It's called digital therapeutics. And it's really about the technology aspect of medicine, which has exploded since COVID. I've mentioned at the very top there, virtual reality. There's actually quite a bit of research being done in virtual reality as far as assessing and treating chronic pain. And it really goes back to the kind of concept of what is that individual's perception of chronic pain. There's an app for that. So there's more than several thousand, hundreds of thousands of apps out there now. A large core of them are health-related apps. There's an app for almost every medical condition you can think of now. There's a large number for mental health, especially. And I think that's exciting, but I also offer caution because there's limited studies showing clear benefits yet. Evidence-based medicine hasn't caught up to the app development. But there are some select studies that show potential benefits for treating certain populations, teens and young adults. There's actually a newer study out showing that older adults may actually benefit as well. And the apps that are more effective or showing more effectiveness are actually ones that focus again on mental health, CBT principles, self-efficacy, education. Well, I know I'm running a little bit behind, and I'm sorry. This is a topic that I could easily talk about for another hour or two, but just to kind of summarize, I think that when we kind of look at the whole of it, current modern theories of pain have definitely evolved. We've gone from the idea that it's a measurable disease or measurable injury to more of what it's a chronic disease state with multiple etiologies and risk factors. Complexities have to include if there's comorbidities, whether they're psychiatric or whether they're substance related as well. Chronic pain is an overactivated nervous system. We know that for certain. And it's that alarm that never really turns off. One of the things we emphasize where I work is that safety really is the goal. You're trying to retrain that brain, to understand that you can still have quality of life, mobility, and seek a retraining so you're not triggering that alarm system. So I appreciate everybody's time. I know that I've gone over, and hopefully y'all found this interesting and useful. I'm going to go ahead and pause because I know we may have some questions or we may not.
Hey, thank you, Lanty, so much. I do not see any questions other than the one that we already answered. And if you do have any, you can certainly send them to events@lakeviewhealth.com. Along with any other issues that you have or anything you want to address. Or if you want to speak directly to Lanty about a particular patient, you can reach her at Dr. Jornby@lakeviewhealth.com. I will put that in the chat. Oh, wait, do we have a question? Hang on, let's see. We need to educate more physicians in order to reduce and stop the RX of opioids. In our experience, Xanax, although not an opioid, for example, has become the aspirin of the day. Sure,
I highly agree. So actually, there was an interesting study I just saw come out today about benzodiazepines emerging now as that. I actually think they might be counting it now as the fifth wave. But if we look at the opioid epidemic history, and we start with the 1990s, where OxyContin and opioids became a safe, and I put that in quotes, a safe prescribing medication for pain. And docs were encouraged and told that it was not addictive. And that evolved into the heroin epidemic and then eventually the fentanyl epidemic, which is where we are now. We've seen an emergence of methamphetamine, but benzodiazepines, absolutely. I like that, the aspirin of the day, because it has definitely been co-prescribed with opioids. I think about my time at the VA where I saw it heavily prescribed together with morphine and methadone. It is a very dangerous drug that I think we're only going to need to tackle in the very near future.
Thank you, Lancy. And then on a personal anecdote from John, I have chronic pain in my back. I generally block it out, but this entire presentation, my lower back has been hurting. Funny.
Oh dear. Sorry about that, John. I know.
All right. On that note, we have some thank yous and everything. And again, please, events@lakeviewhealth.com, Dr. Jornby at lakeviewhealth.com. Everyone has a wonderful weekend. Thanks.
Have a great weekend. Thank you, everybody.